In our quest to improve the quality of life of people with Prader-Willi syndrome, there's no time to stop. No breaks, no rest. We recognize the robust research and progress already achieved through the powerful alliance of patients, parents, families, physicians, and researchers. At Soleno, our goal is to address the challenge of PWS and to develop a safe and effective treatment. And we can't get there without you.
As a parent of a child with PWS, I've learned that I need to use my voice to help advocate for my daughter. We are the voice for our children.
To the patients with PWS and your families and friends who struggle to live a full life with this rare condition, we hear you, we see you, and we support you.
Your passion, energy, and commitment inspire us daily in our quest to improve the quality of life of people with PWS.
Your resilience fuels our determination to develop a treatment that could truly change lives. We're making a difference together.
Welcome everyone to our virtual 2021 PWS Family Conference presented by Soleno Therapeutics. Before we begin today's presentation, let's first thank our amazing sponsors: Soleno Therapeutics, Levo Therapeutics, Harmony Biosciences, Radius Health, Inversago Pharma, Saniona, Conscience Therapeutics, and Novo Nordisk. Their support allowed us to make this conference free for all our community members, and we are incredibly grateful for their contributions. In today's session, Standards of Care for People with PWS, Dr. Jessica Duis will provide an overview of care for people with PWS, supplements, genetics, behavior management, therapy, and more. Dr. Jessica Duis is a board-certified pediatrician and medical geneticist who practices in the area of genetics and complex special care pediatrics. She has focused her career on chromosome 15 disorders, including duplication 15q, and her career has spanned translational, clinical, and bench research. She is passionate about establishing standards of care and personalized therapeutic interventions for individuals with neurodevelopmental disorders. She has designed and worked on many clinical trials and currently focuses on management guidelines and establishing outcome measures that quantitatively capture clinically significant features of neurodevelopmental disorders in the natural environment. Without further ado, I welcome Dr. Jessica Duis.
Thank you so much, Melissa, and to FPWR for having me today. So I'll go ahead and get started. I have a lot of material to cover, so feel free to put some questions into Melissa, or if you have any additional questions that don't get answered, I'm always happy to receive an email. So as Melissa said, I'm going to be covering a broad array of topics on the standard of care from childhood to adulthood for Prader-Willi syndrome. So a few of our objectives are to identify where there is evidence that exists for certain types of management, and then also talk about some of our experiential data without clear evidence for the management of PWS. We'll also talk about features of PWS at this age and potential treatments for them. And then hopefully I'll provide you with resources and tools to help empower you to talk to your providers as well as the schools. So thinking about the clinical criteria of PWS, this was published in 2001 as an expanded guideline for the features of PWS. And there are a few things, particularly in this age range, beyond hypotonia or low muscle tone, concerns about growth hormone deficiency and hyperphagia, as well as delays in learning and development that we see commonly in PWS. And those things that I would add are from birth to 2 would be lack of interest in feeding, Also, the specific features of PWS do include behavioral features, including stubbornness, a need for structure and rigid behavior, OCD type behaviors, a slowed metabolism, and that rapid escalation that you might see from a change in mood from A to Z that can occur very quickly, particularly if there's a change in schedule. There's also skin picking and getting stuck on certain topics and a focus on mealtime. We also have come to recognize that daytime sleepiness and cataplexy, as well as features that are similar to narcolepsy, are present in a large number of individuals with PWS. Seizures are present in about 10% of individuals with PWS. So how many of you felt this way when you got the diagnosis of PWS and just didn't know where to go or what to do? And so the one thing that I always emphasize is the importance of finding your team. If you take anything away from this standard of care discussion, it would be this particular item: to find the people that you can trust and talk to that can help you recharge and find time for yourself and find a support team for you as well. I can't emphasize enough that it's important to be careful on Facebook. There tends to be a lot of posts that are maybe more on the negative side, or individuals who tend to be overly positive. And sometimes we have families come to clinic very upset about recommendations that they've been getting. And everybody has their own lens through which they focus. And it can be hard to get exactly what you're needing from Facebook. And other times it can be a wonderful resource. You have to remember that there's no single right answer. There's a way that some people do things that is right for their family that may not work for you. And so it's very important to keep that in mind. And then there are days that are going to be harder than others, but don't ever lose hope. As you saw with the videos in this session that have been played throughout the conference, there are many wonderful things coming for PWS. So you might have a good day, you might have a bad day, but always wake up the next morning with a renewed attitude if you can. So let's do this. So we're going to go through a lot of different topics pretty quickly, just so that I can cover everything. And then I know these slides in this session will be made available. So when we look at IQ and learning profile for individuals with PWS, the mean IQ that's been reported in the medical literature is between the 60s and 70s, with approximately 40% of kids having borderline disability or low normal intelligence and 20% having moderate disability. And I would argue that this is definitely wrong. I definitely see a lot of individuals with PWS and have personal experience. And I would say that I think our tools through which we assess how kids with PWS learn are really not doing them a service in terms of really analyzing their level of intelligence and how they learn. So I think this is quite outdated data. So the next topic I want to cover is just autism and PWS. And there are a lot of what some might call autistic traits that are part of PWS, in particular sensory seeking. So touching items or needing to feel things to fall asleep, smelling items, inspecting items close to the face, or even holding items close to the ears to feel the vibration, even though the hearing is normal. Lots of repetitive behaviors, so getting stuck on topics and really being focused on topics and asking questions over and over again about the same topic. In the studies that are available, more difficulty with verbal skills were associated with higher ADOS scores, which calls to question the diagnosis of autism in individuals with PWS in some ways, because those verbal skills may be related to developmental concerns such as apraxia. Nonetheless, I would argue that applied behavioral analysis is actually often helpful in kids with PWS, particularly in transition time. So getting started back at school, especially with having been out of school for a long time during the COVID-19 pandemic, we have been making a lot of referrals for autism-based therapy. And a lot of times in working with the therapist, you really want to educate them about PWS. This is where parents are the best advocates for kids with PWS in terms of educating them on what challenges your child faces and having them really, instead of using standard analysis procedures and standard procedures in terms of treatment, really thinking about what might work for your child with PWS. So I do often give the diagnosis of autism so that I can help families have access to certain types of therapies. And it's not wrong because I think they clearly meet the DSM criteria if you put certain features of PWS into certain buckets. And so it's very important to have an advocate and a provider who will do that for you so you can get your child what they need. Therapies are really important and start with early interventional services, usually through the state, OT, PT, and speech. And then there are specialized therapies that are often needed. So feeding therapy can be extremely helpful. There's other therapies that you might hear about out there. So interactive metronome therapy, which uses neurotiming and synchronization of neural impulses to basically bring together multiple modalities. So cognitive, communicative, sensory, and motor performance all together into one therapy. And we have had many families talk about that being successful for their child with PWS. Prompts for restructuring oral and muscular phonetic targets is a therapy that's actually targeted towards apraxia. Apraxia is very common in PWS, and basically, cognitively, the ability to form words are there, but the issue is the motor planning and the ability to actually articulate the words because of those challenges in connecting those cognitive abilities to your mouth to actually get the sounds to come out appropriately. And so oftentimes we use this type of therapy, which is geared towards kids with that apraxia, to work with them to develop language and speech. Hippotherapy can be very helpful. Again, applied behavioral analysis, sensory integration therapy for that sensory seeking. Spider therapy is really a therapy that was developed for cerebral palsy, but really works on muscle strengthening. And cognitive behavioral therapy can be very helpful as individuals get older and you see more of the behaviors that we've been talking about. A lot of families have tried trauma-based therapy, particularly around some of the challenges with transitioning and rigidity that kids with PWS face. And then mindfulness can be very helpful as well. I can't emphasize enough the importance of staying active, not just because it impacts release of endorphins and can help with mood, but also because it just promotes an active lifestyle, which is very important for individuals with PWS. It provides a social group. It doesn't have to be competitive. So oftentimes you can make it competitive in its own way without creating competition that your child feels pressure to perform against other kids. So for example, going to soccer every day or, practicing every day and then going to practices a couple times a week, and a game on the weekend could earn a sticker with a special reward at the end of the week, just to promote that active, healthy lifestyle. Now, one thing I always talk about is the PWS personality, and hopefully this will ring true thinking about your child with PWS. So individuals with PWS are really people pleasers. They want to have a job, they want to be helpful, and they really have certain things that they absolutely love. One of those can actually be to feel like they have a social outlet. Infants and animals are part of that as well. And what we've learned about individuals with PWS is that they actually love competition. So there are certain things like Fitbits and setting goals that almost play into that obsessive compulsive piece, where then you can get them to be more active. So it can serve in a very positive way as well. And you have to sometimes let things go. There's always going to be a bad day where there's just that one last trigger when they get home. A lot of individuals with PWS have a lot of triggers during the day and they just hold it together just until they get home and they feel comfortable to kind of let all that out. And while you have to find a safe outlet, sometimes you just have to let these things go and just move forward. Behavioral outbursts can be very debilitating and a major concern in individuals with PWS, depending especially when they occur, and they can be a problem in terms of safety overall. So behavioral outbursts are defined as becoming very angry or upset in a way that seemed excessive for the situation and beyond the person's control. And these can have all kinds of triggers. I would say one of the most common triggers is expecting an event to occur that then doesn't occur, or that transition time when you're moving from one thing to the next. So sometimes you just have to give them space, distract them to the next activity. They often can occur when there's a change in routine or environmental stressors. I have definitely found that as siblings get older and have more independence driving, and individuals with PWS recognize that their level of independence could be different, doesn't necessarily have to be, but it could be different. That can be a major stressor for kids with PWS. Anxiety, and the part of that can be that perseveration or being very stuck on topics, asking questions over and over again. And sometimes that needs to be treated. And then the other thing I encourage you to consider is sleep apnea, or that excessive daytime sleepiness that we're going to talk briefly more about, and you'll get a whole session on, where they might just be a little bit more irritable at that particular time because they're very sleepy. And so sometimes we write into individual education plans time for kids to sleep, or we think about treating that excessive daytime sleepiness. So we're going to try a poll here. Have you tried a medication for mental health concerns in your child or adult with PWS? And then part 2, what component has to be controlled for medications to be successful in PWS? I'll give you a few minutes to answer that. Okay, let's see what the results show. So it looks like about 40% of responders have tried a medication. And then in terms of what needs to be controlled, a good proportion of people said all of the above, which is absolutely correct. And we're going to talk about that a little bit more going forward. So let's talk about management of these outbursts. So, and just like was highlighted in the poll, really you need to manage the environment first. So the way that the Pittsburgh Partnership often have described this is that if you have a bucket full of water, treating with just medications for PWS is like having a leaky bucket, where you always have some leakage of that water out of the bucket, no matter how much you fill it with medications. And that's really true. So focusing on environment is always the first step to managing behavioral concerns outside of addressing medical issues. So if there's new onset behavioral concerns, we'll talk about some of those medical issues you might think about, like new onset sleep apnea. But in terms of management, you can do a functional behavioral assessment in the setting where outbursts are occurring. So this is basically a detailed time when people are taking a lot of notes about when these instances are occurring. And this can be done by the school system. Oftentimes we're referring for applied behavioral analysis, where they will do this type of assessment if it's happening in the home. And then helping with routine and transition, so using a first then system or a picture schedule. So you'll see over here, there's a detailed picture schedule that includes a lot of different transition times. And on here, it's very important to include meals so that individuals with PWS will feel food secure by knowing when their next meal will be. Guanfacine has been tried and has been shown in the medical literature by Dr. Singh to maybe help with aggression and self-injury. And that's really the only literature that we have. Our experience has not been necessarily the same as Dr. Singh, but it is something that we're willing to try, and we often discuss with parents trying. And then you have to be very careful. A lot of times in PWS, there's a concern for anxiety, which is rightfully so. But a lot of the medications that we use to treat anxiety can actually be what we call activating, and they cause an imbalance of dopamine in the brain to then cause individuals with PWS behavior to actually get worse, even though you are treating an underlying symptom, which is in part anxiety. So you have to be really careful when you're choosing medications with PWS. We often use some protective medications before we would even think about starting a medication that's like a selective serotonin reuptake inhibitor for anxiety. And you are going to get some separate talks on that, so I won't belabor that too much. Magical thinking and psychosis is something that's reported particularly with the uniparental disomy subtype of PWS, but we honestly see this across the board in every subtype. And the way that I like to describe this is often that there is an event that's rooted in reality, but in the individual with PWS's mind, that somehow gets sensationalized or changed over time. And it can border on unsafe. So, for example, I had a patient who wanted to see the Spider-Man movie, very excited about Spider-Man, finally saw the Spider-Man movie. And he was just so excited about Spider-Man that he actually tried to get on a bus and go to New York to save the world as if he was Spider-Man. So it's very rooted in something that he believed, but those thoughts became so obtrusive and bordered on abnormal to the point where he became unsafe. And so that's the type of instance in which a lot of time we're thinking about magical thinking or psychosis, whereas individuals with PWS rarely become floridly psychotic, as you might imagine for other neuropsychiatric concerns that we could have. And so there are medications that work well and some that we have evidence for, the main one being an antipsychotic called risperidone. We often use Topamax or topiramate, and then lithium is one that we use also to help with mood stabilization. Skin picking is very common. And a lot of times when we see skin picking, we'll ask families to get a diary of when this is occurring. If it's happening at school, we'll often ask for a functional behavioral assessment, and that's because skin picking can generally be related to environmental triggers, either anxiety or boredom. So a lot of times we found with those functional behavioral assessments in kids with PWS who are skin picking at school, that either it's during a math topic that they're having trouble understanding and they're becoming disengaged, or a time when there's something coming up in their day that they're getting anxious about. And so having the school collect data on that can be extremely helpful and really eliminate the skin picking without doing any treatments. Treatments of skin picking always start with eliminating the trigger if you can figure it out. Distracting, so sometimes we'll use fidget spinners or having a piece of putty in the hand or rubber bands. You have to be careful because those can also become somewhat obsessive as well. And then a lot of times I've been recommending balms or oils to put on there to make it a little bit harder to gain traction in terms of skin picking. And then I will say a lot of times we hear that Band-Aids are recommending, and most of the time Band-Aids become such an obsession that we're seeing those make the skin picking worse. So we're kind of transition now to nutrition in PWS, and these are the nutritional phases that were established through the natural history study. And you can see here that the early phases of PWS are that lack of interest in feeding. And then as you get into the school age group, you have a period of time where the weight increases before there's a change in appetite in phase 2A. And then in phase 2B, you may see that increased appetite. And phase 3, which generally on average, based on the literature, was said to occur around age 8, is you have hyperphagia. So poll number 2, what is a trigger for food seeking in PWS? Perfect. Okay, we'll go ahead and look at the answers. So a good percentage of people said opportunity, and I think that's definitely true. But we'll talk about some of our thinking about hyperphagia. And so this is changing, and it has been changing for some time in terms of how we think about hyperphagia. So when we've interviewed quite a few individuals with PWS, especially individuals who have a slightly more insight into what's going on, they actually do report feeling full. However, they also report that there are times when they feel like nothing else is on their mind except for eating. And it does seem like anxiety plays a role, boredom. I would also add opportunity, where they have that, that food is always on their mind, and it's more of I would say it's more neuropsychiatrically mediated. And so if they see something, they can't get their mind off of it until they grab it, until they have that in their possession. And so one of the things that can be really helpful is eliminating that opportunity. So restricting access, such as locking, not just restricts their access in a literal sense, but also decreases the anxiety in the household if they know when they wake up at night or when they come home from school that they're just literally not going to be able to get into the refrigerator without help. It decreases their anxiety of that obsession, anxiety around that obsession. So nutritional principles that we'll just briefly go over. So picture schedules that include all activities, including eating, are very important. When you're first introducing foods, we try to say eliminate all added sugars. And then as individuals get older and you maybe notice weight gain, especially in that phase 2A nutritional phase, we often say decrease portion sizes. And then we're mostly talking about balanced meals. And so when we think about balanced meals, we think about a protein and focusing a lot on having a healthy portion of protein, good fats. And then when we think about carbohydrates, we think about carbohydrates with a low glycemic index. So the low glycemic index has to do with how much does your blood sugar get bumped when you first eat a food. And foods that very quickly increase your blood sugar, like simple carbohydrates that start dissolving and digesting as soon as they hit your tongue because of enzymes on your tongue, those are the ones that are probably not the best. So the ones with a glycemic index in the lower range, in particular, non-starchy vegetables like broccoli, lettuce, carrots, are better than those foods that have a high glycemic index, particularly above 50, where they're going to very quickly increase your blood sugar and then drop it down quickly. So I have a little guide here where I'm happy to share the slides so that you can look at it based on your particular child's age. But I would say the guiding principle in every age range is balance. And so I have put together for you just what a balanced plate looks like for each age range. And I'm not going to go over these each individually just in the interest of time, but it's something that I would be happy for you to refer back to. Snacks are really important, and you want to make sure that you're using those snacks that still hold for those same principles where you're getting protein, fat, and then a non-starchy, low glycemic index carbohydrate. And so here's some ideas for snacks. And then drinking water is so important, and it is so hard because a lot of individuals with PWS just don't like to drink water. And so some of the things that we have found are some of the flavored waters can be successful. A lot of times the colder they are, the more they're interested in taking them. And then probably the most successful thing that we've done is talk to families about different recipes for adding things to just plain water. So adding strawberries and basil here. The other thing that we've done a lot of is buying frozen fruits and vegetables because they make the water very cold. And so we've seen kids accept those more. But finding some water-based product that doesn't have any added sugar is extremely helpful. The other thing that I often do with the kids I see in clinic is that I create a reward system with them, with me. So when I see them in clinic, I make a pact with the child that they will drink a certain amount of water and keep track of it. And then if they do very well, we have some small rewards that we give them that are non-food based. And we always have families try to give a glass of water before any meal, including snacks. So the idea being that in order to get served their meal, everyone in the family, not just the individual with PWS, has to drink a full cup of water, and that can be very successful too. Just a word about growth hormone. This is the most clear standard of care in PWS. It's FDA approved, and it really should be given throughout life. And the reason for this is that it doesn't just have benefits in terms of growth, but there are other benefits. So there are benefits potentially in terms of IQ and learning. There's also benefits that we definitely see in body habitus in terms of maintaining um, a lot of adipose tissue versus lean muscle mass. And so that is very important to continue growth hormone. So even after growth plates are closed, we strongly recommend continuing a very low dose, or what we call an adult dose of growth hormone, which is usually 0.3 or 0.4 milligrams, so a very low dose, to help with the additional benefits that we see with growth hormone. And there was a lot of concern about growth hormone, in particular, an impact on tonsillar size and causing enlargement of the tonsils, which then affected sleep, disordered breathing. And many of the studies have shown that that is not to be long-term the case, and that growth hormone should be used in individuals with PWS for all of its benefits. I would say the main contraindications would be if there's any uncontrolled diabetes, getting that under control, and then severe obesity can be a contraindication to giving growth hormone. And this is just to show that if you look at this is verbal IQ and full scale IQ. And if you look at this, the blue is individuals who are on growth hormone, and the red is individuals who have not been on growth hormone. And you can see that in this study, it looked like there were some benefits cognitively for individuals with PWS on growth hormone. Sex hormones are a very tough topic to spend such a little amount of time on. Overall, I would say the main thing is that there are benefits to being on sex hormones that are very important, in particular around bone health. And so this requires a discussion with your endocrinologist on what's best for your child. A lot of times we will start with a small introduction of estrogen. So could be a patch and not a full size patch, but maybe a quarter size patch to start. And you can transition that over to pills if the full patch is effective and the individual's tolerating it. And then even when you use birth control pills, you still need every few months to take those placebo pills so that the lining of the uterus doesn't get too thick. And then males as well, it can be very helpful for help males gain confidence to be on testosterone. And there's different ways that we can dose testosterone to maybe start at a very low dose if that's preferred. Reflux remains a big problem in PWS, even in the childhood to adult age range. And it's early on present in a large proportion of individuals with PWS. Sometimes if there's a change in behavior or awakening at night, that can also be reflux in PWS. And so we generally use standard of care medications to treat that. Constipation is a major problem in PWS. And we can often see severe distension in the belly because of kids having severe constipation. This can also present with soiling, so having accidents at school. And so it's very important sometimes to just go ahead and get an x-ray and look for that. There's some ways to treat it. MCT oil, especially if you're on one of those diets where you're adding good fats, MCT can be a good way to add that to diet and also can help with going to the bathroom. I recently learned about this squatty potty, actually in a personal way. I was talking about constipation in this population, and this was actually recommended by my sister, and it changed her life. So squatty potties are little stools that you can put underneath the toilet, as you see here. And as I said, she said that changed her life. So I started recommending this. And I have heard that from several kids now, that just getting at the right angle because the low muscle tone has helped them significantly. So gastroparesis, where you basically have clinically diagnosed load emptying from your gut, which can also cause chronic episodic ballooning out or lots of gas in the belly, can be very common in PWS, doesn't tend to be life-threatening. And a lot of times we try specific diets to try to help with this. You can also use medications that help things move through the gut a little bit quicker. And there's a link here for some specific diets, but just small frequent meals can be helpful. Soft foods, eating your solids earlier in the day, making sure you're sitting up while you're eating, and chewing foods thoroughly. So there are a lot of supplements that we can talk about in PWS, and the guiding principle here, I would say, is not to introduce more than one at a time. So I would give it at least a 2-week trial before adding another one. And similarly, if you don't see a benefit, stop the one that you're using, because there may be some side effects to them that we're not as aware of, or that we could be concerned about if you continue them, especially if they're not having benefit. And the bottom line is just there's not a lot of evidence base out there for us to make specific suggestions. So there are a lot of these supplements. I'm not going to talk about all of them. Coenzyme Q10 is one that has been used in individuals with PWS, even from a very young age. It may be helpful for those factories of the cell called the mitochondria that help us with production of energy in our body called ATP. And so they may be targeting that. There's some evidence that maybe they're helpful for stamina in general. And some individuals have reported that there could be some impact on psychomotor development. We often use a dose of 100 to 200 milligrams per day, and there's no randomized controlled trial to tell us if this is helpful. So this is one, you can buy it over the counter or talk to your provider about it, and then you would just try it and see if you think it's helping your child. Levocarnitine is another one. There haven't been significant differences when we look at the level of carnitine, which is basically a vitamin that's very important for how we move fats into our mitochondria to allow them to be made into energy. And there's not a lot of data that vitamin is low in the body. They may be helpful for daytime energy and alertness. And there was a study by Art Baudet that came out in 2017 that deficiency in levocarnitine may be linked to non-syndromic autism. And so this is one that we also support families if they would like to try, but there is no clear evidence and no randomized controlled trial to suggest that it's beneficial. MCT oil, we talked a little bit, may be helpful in augmenting some of those higher protein and fat diets focused on healthier carbohydrates. And there is some data that one part of PWS is the transformation of active ghrelin, which is our hormone that tells us we're full, to its active form, so inactive to active ghrelin, may be impacted by MCT oil. And so there may be some additional benefit of this. Again, there's never been a specific study in PWS. There have been studies in overweight individuals that it might help with a reduction of appetite and food intake. And so we do often try this, and I put the dose on there for you. B vitamins are cofactors in many important reactions of the body, including production of the hormones in the brain called neurotransmitters. And if you don't have enough B12, you can see cognitive difficulties, problems with balance, things that have been associated with PWS. Individuals with PWS, whether or not they're on supplements, in our experience, have a really high B12 level. And so we're not sure if it's an ability to use B12 effectively in an active form. And so there are some individuals that have tried even B12 injections, but we don't have any data available to know if this is beneficial. DHA is another supplement for and has been used in kids with autism or ADHD. There's no really data in PWS, but omega vitamins, fish oil, which often have DHA, may be helpful for specific psychiatric disorders and some of the overlapping features we sometimes see in PWS. And so this is another one that we see people use all the time, but not necessarily that we have clear evidence for. For skin picking, there was one study that was, actually there have been a couple studies now. The original one done by Morris Angulo in 2014 and Dr. Miller showed that N-acetylcysteine, because it's a very strong antioxidant, may be helpful for skin picking. The way that we typically use it is at the height of skin picking. We'll often recommend a trial of it, but oftentimes using it chronically, we see that it becomes ineffective. And this may be also helpful for treating anxiety based on some of the medical literature. Multivitamins are very important, particularly if you're following a pretty restrictive diet, which we sometimes see. And a lot of these options definitely are ketogenic friendly or promoting some of those diets with the higher protein, less carbohydrate, higher fat diets. So these are some examples of balanced multivitamins that we like. The Nano VM is helpful because it's a powder. It doesn't have a good taste, and so it's very safe in terms of preventing kids from getting into it. I do want to take a second to talk about sleep disordered breathing because we are recognizing that this is a huge part of PWS that, you know, even 10 years ago and during the natural history study, we didn't recognize how important this was. So individuals with PWS, up to 80% of them have that excessive daytime sleepiness, which can manifest in many different ways. A lot of times we see just very quick to fall asleep. So one family told me their child will just lean anywhere, even standing up, and just fall right to sleep. It can manifest as irritability and more behavioral outbursts and behavioral problems, change in performance and how kids are doing at school is a big symptom of that as well. Disorders of arousal also are part of PWS. So when we look at their response to low oxygen and high levels of carbon dioxide, individuals with PWS don't respond appropriately to those changes in environment. And sleep disorder breathing is a huge part of PWS. So obstructive sleep apnea, decreased oxygen during sleep, shallow breathing where they hypoventilate and have a rise in their carbon dioxide. It's very common. So our last poll, how might narcolepsy and cataplexy commonly present in children and adults with PWS? I'll give you 30 seconds or so. And let's see what the answers are here. So most people said all of the above, which I definitely would agree with you on that one. So just a word about narcoleptic and cataplectic features in PWS. These are common. And you can see from the picture I have here, so cognitive impairment, disordered sleep behaviors, problems with regulating food intake, ADHD, anxiety, those kind of sensationalizing things or not thinking about things rationally, depression. All of these are also part of PWS in a way. And so I think that this narcolepsy cataplexy piece of PWS is very common. And one of the ways we first see that manifest is when infants and young children are starting solids and they're sitting in their high chair or whatever supportive chair they're sitting in, and they start eating and their eyes kind of close and you kind of see their head drop. That may be an early feature of cataplexy. So sleep disturbances are common. Just very quickly through management, because I want to have some time for questions. Very important to get growth hormone started. The starting growth hormone does require some data. And what we do at our center, and what I've done in the past is to, especially if kids are in the NICU, just look at the pattern of breathing in the NICU, often get started as soon as possible on growth hormone. And then they do need that repeat sleep study at 8 to 10 weeks, which is part of the FDA guideline for initiating growth hormone in PWS. The one thing I would say about that is that it does often take at least 2 to 4 months or so, at least at our center, to get a sleep study done in an individual or with PWS or any infant. If there's obstructive sleep apnea, there may be some surgical options. So referral to ENT can be helpful. Sometimes continuous positive airway pressure is recommended if there's no surgical options, or even if there's additional sleep apnea once surgery has been pursued. Central apnea is where your brain doesn't tell your body to appropriately take a breath when it's needed. So those triggers should be low oxygen, high carbon dioxide, but sometimes that doesn't happen in PWS. And so for that, as individuals get older, we're often recommending PAP therapy. In infants, it's really oxygen therapy that we recommend. And then we are often treating excessive daytime sleepiness because of the impact on other aspects of PWS. So there are some studies on a drug called modafinil, which is a mild stimulant. The mechanism of action is not well known, but it may be helpful and is something we can try. And then pitolisant is in clinical trials currently and definitely encourage participation in that. It is also available with a diagnosis of narcolepsy in individuals who are adults. And so we do sometimes also try to get that for kids with PWS. There are some studies that have been published where case reports really of our case groups of families got together and imported pitolisant and were able to look at some of its impacts. And it does look like it has more widespread impacts related to maybe some of that difficulty learning, irritability part of being sleepy. So lots of complications of sleep apnea. I think I've mentioned some of these. There are some long-term heart complications, so has to be on your mind if your child is not compliant with their treatment for sleep apnea, such as PAP therapy. We really recommend getting echoes, so ultrasounds of the heart to look at that. other things, scoliosis, we recommend getting regular x-rays because there can be this S-shaped curve. So it's when you look at the x-ray, literally there's a curve at the top and a curve at the bottom. But when you look at the child, because that evens out to a straight spine, sometimes we miss that. And so we generally get early yearly x-rays. We have some kids who have pretty bad allergies, and eosinophilic esophagitis is something we've seen in this population that we're not sure if it's specifically related to PWS. Oxytocin, I could talk about for a long time. The bottom line is the studies are very variable. We definitely have anecdotally seen that families feel like it's helpful, particularly for social cues and social behavior. And maybe early on for feeding, and then carbetocin from Levo Therapeutics is under review, and it may be helpful for hyperphagia and anxiety. So our goal is to continue to do research so that we can publish evidence on the best way to manage PWS, but we're just not there. We don't have a lot of randomized controlled studies. And then I just can't emphasize enough how exciting the future is for PWS. There's so many medications in clinical trial. The DCCR study looks very promising with some positive results that I know have been presented. Pitolisant already has some data in PWS, and then there's many studies coming, many companies interested in PWS, so don't ever lose hope. So I'll stop there for questions. I'm sorry that I went a little over, but I'm happy to stay for questions and for anyone to email me.
Thank you so much. That was so informative. We do have a few questions. So let me pull those up. The first question that we have is, how best is childhood apraxia addressed, and how does it transition as a child grows?
That's a great question. So I think working closely with a speech and language therapist who knows a lot about apraxia, and there are some specific speech and language therapy methods such as prompt, but there are many others as well, that you want to get a speech and language therapist who, even if they're not specifically trained in those, they will implement and learn those techniques. And there's lots of videos and things that you can watch on YouTube to kind of help with that. Generally, apraxia gets better. So with therapies, apraxia does tend to get better in this population where speech can be better understood, but there is a subpopulation of kids with PWS who need a speech and language device, so an augmentative and assistive communication device, just to help them, particularly when they're at school and they're not around people who know them very well, to know exactly what they're saying so that they don't become frustrated. And that has been life-changing for a lot of the kids that we see with apraxia.
Great. The next question is there any incidence of Tourette's in PWS? This person has a 12-year-old daughter that looks like facial tics or seizures, but they've been to doctors and they found no seizure activity in the brain. They're just wondering if that is common. She blinks repeatedly, rolls her eyes, gapes her mouth, etc.
That's a great question. I would say the incidence of a true diagnosis of Tourette's with PWS is not necessarily higher than the general population, but we do see a lot of those anxious, repetitive behaviors like eye blinking. Like we see kids do this a lot with PWS. And I would say they may not formally be diagnosed with Tourette syndrome, but it's that same anxious, perseverative personality. And so sometimes implementation of treatments like guanfacine or clonidine can be really helpful. Thinking about it, I have several kids who have a diagnosis of Tourette's, but I would say if you look at the general population, it's probably 1% to 2% that have Tourette's and of the population of kids with PWS that I see, it's probably the same. But same treatment principles, and sometimes I would say they're a little more effective in PWS than they would be just in kids with generalized tic disorders.
Great. We have two people asked a question. I know you mentioned this briefly, but they were wondering about what the adult dose for growth hormone was that you had recommended.
Yeah, so all of us still have release of growth hormone even when our growth plates are closed. It's just a very low dose. So typically, I mean, this should be done in consultation with an endocrinologist, but I would say 0.3 or 0.4 milligrams is generally what I see endocrinologists doing for the adult dose.
You had briefly mentioned about anxiety meds that are activating. So this person is asking what anxiety meds are activating, or is it in general?
Yeah, so we have some data about this. Unfortunately, it's not published, but selective serotonin reuptake inhibitors, particularly very long-acting ones like Prozac or fluoxetine, are generally tend to be activating, meaning that they tend to make some of those aggressive symptoms, impulsive symptoms, sensationalizing symptoms a little bit worse when you're on them. The other one that we have seen be activating in PWS is Abilify, which is actually an antipsychotic, but we have seen symptoms get worse in a lot of kids on Abilify in PWS.
Good to know. The next question is, what questions should I be asking my endocrinologist to know when is the right time to use testosterone? Are there tests that should be completed to help the doctor make these recommendations?
Great question. I would say generally around the time that boys start puberty or would be clearly in puberty, checking, but this can also be based on checking testosterone levels. And so we often will check hormone levels to help us decide. So that should be done in consultation with an endocrinologist for sure. But 12 or 13 is often when we'll start.
This one is asking about the dosage for MCT oil. Could you mention that one more time?
Yeah, we often start with 1 teaspoon a day with meals. 1 teaspoon once a day with a meal. And then if the individual is tolerating it, you can go up to as much as 3 times a day.
Are there medicines that work better for ADD in kids with PWS than others, or ones that should be avoided?
That's a great question too. I definitely have kids who have PWS who are on traditional stimulants. You have to be careful because stimulants can make anxiety worse, which can make a lot of symptoms worse in PWS. So my, in general, go-to would be to first assess those sleep concerns, the excessive daytime sleepiness, and consider actually doing a milder stimulant that's not traditionally used for ADHD. So something like that modafinil first as a place to start. But sometimes we end up on Adderall or Focalin, and it's just a question of monitoring really closely, making sure, for example, that skin picking doesn't get much worse.
Great. The next question is, any research studies or experience with individuals who are not sleepy but quite energetic, rising early, go, and lies awake at least 30 minutes before falling asleep? This sounds like my son. There's no signs of breathing issues or sleepy behaviors during the day.
Yes. So I always assess to see if there's any of that sensationalizing behavior or any concerns about that, because that can go along with some of those magical thinking type behaviors of, almost being like very up instead of more down. And so we always assess for that when we see it. And sometimes we do put them on a medication to help them sleep that takes that doesn't take away their energy, because we don't want to do that, but helps with some of those racing thoughts that they have that are contributing to that particular presentation.
Great. So this next person has a daughter who's 10. They've noticed characteristics of cataplexy numerous times in her life, more so when she was younger. They seem to be prevalent when she's going through a growth spurt, and she does not get them as often as the older she gets. She's never been officially diagnosed. Is there a need for a diagnosis or for a need to be addressed on a medical level?
Only if it's causing a problem. I mean, I definitely think we have medications that if she gets a formal diagnosis of narcolepsy / cataplexy that we could offer to see if it helps. You know, cataplexy can sometimes be dangerous in terms of dropping quickly to the ground or falling asleep at inopportune times. So, you know, sometimes we do treat it if there's a concern on a safety level.
Let's see. Someone asked, let's see, their son has had 2 endoscopies for reflux and found eosinophilic esophagitis. I think they want you to elaborate a little on it in regards to food allergies. And disclosure, my son has eosinophilic esophagitis as well.
We definitely see eosinophilic esophagitis in PWS at probably a higher rate than the general population. It is hard to answer that question. Generally, getting reflux under control would be the first treatment. But yes, a lot of times we end up doing an elimination diet for severe eosinophilic esophagitis to see if there are food allergies contributing. And I will say often there are.
Yes, definitely. Let's see. Impact of music on behavior and anxiety, music therapy. That was their question.
That is a very individualized question. I would say a lot of individuals with PWS love music. And so if you're appealing to that interest of theirs, then yes, I think that can be a good way to help manage. In particular, if you work, sometimes this takes working with a good applied behavioral analyst or BCABA who can work with your child to utilize music as a coping mechanism. So for example, at those moments when they're escalating from A to Z very quickly, having them take a second, go in a quiet space, put on their headphones and listen to music can be extremely effective.
We had a couple of questions on research and treatment for rectal picking.
Rectal picking is very, very challenging. I would say the first thing you need to do is make sure that there's not constipation. So a lot of times making sure that there's nothing stuck in the rectum, which is common in PWS where you have a hard piece of stool in the rectum, that can really stimulate kids to have an interest in rectal picking. A lot of times treating anxiety can be helpful as well.
Okay, there's a question. So this person's psychologist did not give an autism diagnosis for their 6-year-old PWS and mentioned that at this age, ABA is more focused on social aspects, which he does not currently struggle with. Is this accurate, or should we still be pushing for ABA even if he is socially is typical?
It depends what issues that you're seeing, but I find ABA extremely helpful for just even at 6 with environmental interaction and transitions and coping. And so I am a big supporter of pushing to get ABA therapy.
Are adults with PWS able to get insurance coverage for growth hormone without a growth hormone stimulus test positive? Patient was on until growth plates closed.
That's a good question. A lot of times we write a letter and we provide the data from the medical literature, which there's a growing body of evidence in adults in fighting for it. Having the endocrinologist fight for it has been enough not to have to get a growth hormone stimulation test.
One of my twins with PWS has attention disorder. Do you notice that in others, do you think treatment can be effective? Are there any side effects?
Definitely attention is part of PWS, so having difficulties with attention. A lot of times, again, we'll start with thinking about whether there's excessive sleepiness involved that are impacting ability to pay attention. But oftentimes we do, and we oftentimes will use like a milder stimulant to help with this symptom, but it's very, very common.
Is there a correlation between individuals with PWS and a higher rate of cerebral seizures in the early years? Any additional concerns one should watch for if their child has PWS and cerebral seizures?
Yes, so seizures are more common in the PWS population than we had originally thought. We actually have a paper looking at the global PWS registry data that should be coming out soon. And I will share that individuals who have seizures, febrile seizures, and seizures as infants and younger kids often go on to have that narcolepsy, cataplexy, like clinical features of PWS. And so that's something that I would definitely encourage looking for in terms of effective treatment.
Do you recommend all PWS adult females be on HRT?
That is a really good question. I think it is an individualized discussion with the endocrinologist, but there are a lot of benefits that we rely on hormones to help us with, one of which is bone health. And so I think working with an endocrinologist who's at least monitoring that and individualizing a plan with you around that is very important.
Aside from growth hormone, is there anything else you recommend specifically for adults with PWS?
That is the only FDA-approved medication for PWS right now. So I think otherwise, the main things I would focus on are symptom-based management and watching for some of these areas that we've been talking about, like narcolepsy, cataplexy, behavioral concerns, new onset of strange or unusual behaviors, worsening behavioral outbursts, and then it's an individualized discussion about whether anything is needed for any of those concerns, whether it be therapy-based or medication-based.
What do you think about CBD oil for anxiety disorders, and what advice would you give regarding that?
That's also very individualized. We definitely have kids here, especially in Colorado, using that. And the response is a little bit variable. Luckily, we do have a company that's rolling out a placebo-controlled trial on CBD oil so that we can know for sure if there's an impact in PWS. So I would say stay tuned for that trial. But right now it's all anecdotal and very variable, what it helps with and which particular kids with PWS it does help.
What are the best medications for PWS for anxiety?
I think you guys are going to have a talk about that. Is that right, Melissa?
Yes, we'll have a talk about anxiety and a talk about the mental health, this week. Yes.
Okay. I mean, there are certain go-to things we definitely use, which I'm happy to talk about, but I think the main thing would be to ask those questions in those sessions.
And then the last question we got was, is there a correlation in some of the drugs for daytime sleepiness for increased anxiety? She specifically put, is it modafinil?
Yes, modafinil, yeah.
Modafinil.
We do sometimes see that. In particular, we can see skin picking get worse. So it's something that we monitor very closely. But it's kind of like a catch-22 in that it can be a side effect, but sometimes the symptoms that we're treating overall help those particular areas as well. If it's, for example, if it's the attention piece and they're getting bored in skin picking and we help that attention piece with the mild stimulant part of modafinil, sometimes those symptoms go down. So it just takes close monitoring and working with your doctor to figure out what the best medication is or combination of medications is.
Perfect. Well, we would love to thank you, Dr. Jessica Duis, for joining us today. Your sessions are always so insightful and it's so helpful for families. So I just want to say thank you so much for joining us today.
It's a pleasure. Yeah, thank you. And please don't hesitate to reach out if I can answer any additional questions.